Someshwar, you're on live, please.
Yeah, thank you, Ashwant. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to please do share your queries in the comment box so that at the end of the webinar, we'll have a short Q&A session. So, and let me welcome our today's eminent speaker, Dr. Hello. Yeah. Let me welcome today's eminent speaker, Dr. Kavita Bapat. Hello. Yeah. Hello.
Yes, sir. We can hear you, sir.
Yeah. Sorry. So let me welcome our today's eminent speaker, Dr. Kavita Bapat ma'am, who is Vice President at Foxy from 2021 to 2022 and organizing secretary from AACOG Indore. And she's the director of Bapat Hospital Indore, and she's a one-day hysterectomy specialist and also ICOG vaginal surgery certificate course center and Jogi peer reviewer and editor at Apollo Medicine and initiator registry of primary ovarian insufficiency. And she's award winner of NICA Indoor and Captain of Industry and Vice President AMPOG and President Indoor Menopause Society and Vice President MP Chapter of Vaginal Surgeons. And she's also Secretary of MP IAGE and Executive Member of ICER and IAGE. And also she is a past Governing Council member of ICOG and Chairperson Breast Committee of Foxy 2016 to 18. And with this, we welcome you for today's webinar, ma'am. And we are very honored to have you, ma'am. And present webinar is streamed through the Shield Connect, which is the digital platform of Shield. And I request all the delegates, if you miss any part of this program, it will be available in the Shield Connect webpage. And coming to the today's topic, poor ovarian reserve. As we know that ART is muchly affected with the poor insufficiency, which can lead to adverse effects. So without wasting much time, let me turn over the time to Dr. Kavita ma'am to talk on poor ovarian insufficiency. Over to you, ma'am.
Thank you so much. Really, I'm obliged, Shield, for giving me the chance to speak on the subject with whom I have started a registry of the poor ovarian insufficiency. I think I'm audible as well as my slides are.
Yes.
Slides are. So thank you so much for giving me the chance again. The primary ovarian insufficiency, poor ovarian reserve, these are the few things which we talk about. And thank you so much for my introduction. And I have started a registry on POI. This is anybody can get, there is a link and you can register yourself for the primaryovarianinsufficiency.com. There is this thing. Now, these are the terminologies from the primary ovarian insufficiency. We can say they are synonymous, or sometimes we can say they are interchangeable words. Number one is a premature ovarian failure. Another is a primary ovarian insufficiency. And third is a premature menopause. So nowadays they have changed the term and given it's a premature ovarian insufficiency, or poor ovarian reserve has given this word is a cessation of menstruation in women under the age of 40. Number one. Number two, there is an elevated serum FSH levels more than 25 international unit per L. And at two separate occasions, at least 1 month apart, there is a concomitant low estradiol. That's a less than 50 picogram in the unit forms. So this is the latest definition for the premature efficiency. So we should know there should be amenorrhea, there should be elevated FSH, and there is a concomitant low estradiol. And amenorrhea is at least for 4 months. So things are FSH less than 40, clinical hallmarks, sustained amenorrhea, infertility, hot flushes, vaginal hot atrophy. The age less than 40 years. Then important point is number of primordial follicles accelerated atresia, impaired follicular function. There is a definitely decreased into the primordial follicle numbers. And then the estrogen is less than 50. So these are the clinical things or the biomarkers which makes this is a premature ovarian insufficiency. So just to remember, less than 40, more than 40 FSH, estrogen less than 50, and primordial follicles are less, and there are the amenorrhea, infertility, hot flashes, vaginal atrophy. The patient can come with anything. Now, while I going and reading about it, the years and the incidence is 1 in 10,000 at the age of 20. At the age of 30, the incidence is 1 in 1,000. At 35, the incidence is 1 in 250. And at the age of 40, the incidence is 1 in 100. So we cannot leave this topic unnoticed because the premature ovarian insufficiency is the topic which covers many fields, right from the pediatrician or those who are treating the adults and girls, number one. Because these are the patients, sometimes the transgenders and all those patients come into those pool. Then all the chemotherapy or the oncophysicians, they treat the patients with the this thing, and these patients can end up into the premature ovarian insufficiency. Then there are the reproductive medicines or the endocrinologists, they treat the premature ovarian insufficiency. So I say it's not a topic of one subject, it's a multidisciplinary thing. And these are the reasons. Primary is it's a X chromosomal disorders. X chromosome deletion, inversion, duplication, balance, translocation. There are many, but the Turner syndrome is very important. XO and the mosaics. Triple X syndrome is triple X, and the fragile X. This is also very important. FMRI gene permutation carrier. Then DIA PH2 translocation. Then BMP 15 variants. And then PGRMCI variants. There are genetic syndromes also other than X chromosomal disorders. They are ataxia, telangiectasia, Fanconi's anemia is also very important. Then Bloom and Warner's premature aging syndromes, that is BPES, and other single gene variants. So these are the primary premature ovarian insufficiency. So it's very important. And the other primary are maybe due to the enzyme deficiency, galactosemia, 70-alpha hydroxylase, aromatase, and autoimmune disorders, polyglandular autoimmune syndrome type 1 and 2, primary adrenal insufficiency, autoimmune thyroiditis, and non-endocrine conditions, that is a SLE, pernicious anemia, and myasthenia gravis. That's the reason, because the poor reserve may be due to these primary reasons, and that's why it's not only the subject of gynecologist or the infertility specialist, but it is also subject of endocrinologist and many more. Now there are the secondary things which causes premature ovarian infections or insufficiency. It may be due to the infections. Infections can be viral, mumps, cytomegalovirus, and varicella. Bacterial can be tuberculosis and Shigella. Parasitic can be malaria. Toxin and injury, chemotherapy, for example, alkylating agent, radiation, pelvic surgery, oophorectomy, and smoking. So there are selected single genes associated with primary ovarian insufficiency. It's a big list. I'm not going much into detail of them because they are very important, but they are there. Then DNA damage repair genes, there can be ovarian function genes. So there is a names and a number. So it's really a very big list. Now the important thing is chemotherapy and radiation exposure can cause the premature ovarian insufficiency. There are few chemotherapeutic agents and there is a radiation dose at the age of exposure. So these are the alkylating agents, chemotherapy, that's a nitrogen mustard, chlorambucil, cyclophosphamide, busulfan, melphalan, and dicarbazine. Because in a young age, any carcinoma, anything in a young age, if the patient has been given the chemotherapeutic agent, there are chances and the risk of premature ovarian insufficiency. Same with the radiation. It's very important. If the 20.3 gyrus at the birth, there are chances of premature ovarian insufficiency. 18.4 at the age 10, 16.5 at 20, 14.3 at 30, and 6 at the age of 40 and more. So the radiation exposure is one of the very, very important reason for the premature ovarian insufficiency. We are seeing young patients with ovarian malignancy, or sometimes we see the patients, young patients with the breast malignancies, and they get the radiation, and sometimes these things can happen. These are the another chemotherapeutic agents like the anthracycline, doxorubicin, and these are the things. Then there are substituted hydrazine, that's a procarbazine. These are responsible for premature ovarian. Now, how they work on it? They make two things. Number one, they do the follicle dysfunction, and other thing they do is a follicle depletion. Follicle dysfunction, follicle remains in the ovary, but pathological process prevents the normal function. For example, FSH receptor mutation is there. But there is sometimes follicular depletion. There is no primordial follicles into the ovary, and failure of establishment of adequate initial pool of primordial follicle into the uterine life. And there is an accelerated expenditure of the follicle. So there can be a dysfunction, there can be a depletion. There are two things, both can happen, and the reason and the cause may be different. And follicular depletion can be due to the autoimmune or a toxic destruction of the follicles. So there are the selected genes involved into ovarian follicle activation, maturation, and death. So these are the few genes: FMRI1, PG, RMC1, POR, R3H. They either act on the follicle activation or they act onto the follicular development and the maturation. So the primordial and into the primary, prenatal, early antral, and late antral, they can act at different levels and they can cause the follicular death. So then a clinical presentation is very simple. There are menstrual abnormalities, missed cycle leading to amenorrhea, sudden onset of secondary amenorrhea, or sometimes primary amenorrhea. Patient can come with some infertility or infertility. Sometimes menopausal symptoms are also there: hot flushes, vaginal dryness, sleep disturbances. Then there is a changes into the skin pigmentation, vitiligo, hyperpigmentation because of adrenal insufficiency, hair loss, alopecia, can be autoimmune. Goiter, though it's a cause for the premature ovarian insufficiency, and the patient can come with the symptoms and signs of goiter. Fatigue is also there, anxiety and depression. So the diagnostic consideration and evaluation, where to diagnose and where to, how to say it. So these are the few laboratory tests and what is the rationale. The number one is most important. When there is an amenorrhea of 4 months or anything, we cannot blame the patient that she is having the premature ovarian insufficiency. So the first and foremost test, which is most important and needed, that is a SCG, and then the FSH and estradiol, then anti-Mullerian hormone, inhibin B. Then the time comes the karyotyping, fragile X, mental retardation, that is fMRI1 permutation. Then TSH, thyroid peroxidase antibody, and 21-hydroxylase antibody. And then the radiologist test, that's a transvaginal ultrasound. And dual energy X absorptiometry. So XCG, it excludes pregnancy. FSH and estradiol assess hypothalamo-pituitary ovarian axis. Anti-Mullerian hormone and inhibin assess the ovarian reserve. Karyotypes, they evaluate the genetic etiology. Then thyroid and all those things evaluate the thyroid function and quantify the risk of thyroid and adrenal dysfunction. And the transvaginal sonography is for the antral follicular count to assess the ovarian reserve. And dual energy X-ray absorptiometry to assess the bone density. So these are the diagnostic consideration and evaluation. But the sequence of POI are very important. I was reading it, I was really surprised by myself also. There are high mortality rates than those patients who are having a POI. There is an increased cardiovascular risk. There is a poor quality of life. There is a reduced fertility, reduced BMD, increased fracture risk, and genitourinary symptoms are also there. So the worrisome is basically the menopausal symptoms, cardiovascular health, infections, bone health, emotional health, and most important for the infertility people, the infertility and the cognition. So for the menopausal symptoms are there, and the patient is not worried about the infertility, systemic estrogen replacement, local estrogen replacement, testosterone supplementation is there. For good cardiovascular health, as there is been estrogen has a beneficial effect on a cholesterol metabolism, lessening the atherosclerotic plaque formation, prevents the coronary constriction, and early initiation of hormone therapy following the onset of menopause has been suggested as a cardioprotective strategy. It's been into the ESHRE guidelines, and it has been a Weber L. and Davis M. et al. Has been in a human reproduction in 2016. Bone health is also important. Fracture risk in the later life risk can be mitigated with the use of hormonal therapy, and the serial monitoring of bone mass within 2 to 5 years of the initiating hormone therapy is warranted until recommended at the age of 65. For the bone health, again, weight-bearing exercises, dietary calcium, vitamin D, avoidance of cigarette, and this is a lifestyle modification is very, very important. And constitution use of non-hormonal anti-resorptive agents for the fracture risk reduction is also important. But the most important thing is, another is a cognition is important. That's a rapid cognitive decline and strategy to minimize the neurocognitive disorder by logical benchmark to guide the use of hormone therapy until the age of natural menopause. This is the only one condition, premature ovarian, this thing where the hormonal therapy is a must, and that should be given as early as possible, and it should be continued until the normal age of natural menopause, that is 47 in our country. So this is the like a very, we cannot, there is no debate about it to give the estrogen or not to give the estrogen for the premature ovarian insufficiency. This hormone therapy is must. For the emotional health, psychological counseling, multidisciplinary team to provide the continued observation, coping strategies to address the unmet need. Now, the most important is infertility. The first point is up to 25% patients spontaneously ovulate, 5 to 10% conceive naturally. Number third, no intervention that can reliably improve the residual ovarian reserve. So whatever you do, there are the chances of not improving. Then the use of donor eggs, which can improve the conception rate. And another important point, if the patient is not concerned about the infertility, contraceptive strategies should be recommended to avoid pregnancy. Stem cell therapy via residual follicle rescue is also in a latest methods for improving the infertility. Injected bone marrow derived stem cell, peripheral blood mononuclear. Another is a platelet-rich plasma, increasing the concentration of local growth factors within the ovary, utilizing the intra-ovarian injection of cell therapy, and then ovarian tissue cryopreservation, that is OTC, in which the portion of entire ovary is removed, frozen with the intention of autotransplantation. So these are the coming up things for the infertility. PRP is a partially restore the function of POI ovaries, prompt morphologically normal follicle from degeneration and atresia caused by the ovotoxic chemicals. PRP, it stimulates the angiogenesis, good capacity for tissue rejuvenation, inflammation regulation, minimizing the histopathological damage, promoting the neutrophil counts, and important effect on the therapeutic outcomes. There are so many research, so many things are into the PRP field also. Not been found to increase the risk of breast cancer before the age of natural menopause. So progesterone should be added in combination of estrogen therapy to protect the endometrium of the woman with the intact uterus. Now the hormone treatment, I already suggested the goal of hormone therapy to mimic the endogenous level of hormones, which equates the serum E2 level up to 100 picogram. And once initiated, hormone therapy should be continued until the age of natural menopause. Average age all over the world is 51, but in our country, it's a 47 years. So these are other ESHRE guidelines for the woman with the premature insufficiency. But there are few points to be noted that if there is a prepubertal premature ovarian insufficiency, onset of predates the onset of puberty. It's a stigma of failure of ovarian estronization include lacking secondary sex characters, retarded skeletal growth, primary amenorrhea. Turner syndrome is a prototype for the prepubertal POI, and complete ovarian failure during childhood, such as a whole body radiation or a bone marrow transplant, would have a similar consequences. Again, the prepubertal, the goal of HT to achieve the exposure, increasing estrogen levels in a progressive fashion over the months, starting a very loads of 17 beta estradiol. Typical regime is 6.25 per day. of 17-beta estradiol transdermally or micronized oral estradiol 0.2 milligram daily, and it should gradually increase every 3 to 6 months over the course of 2 years until an adult dose is reached, or spontaneous menses ensues, then at which point cyclical progesterone regime is to be added and the endometrial protection. Then there is a post-pubertal premature ovarian insufficiency, require higher dose of systemic estrogen. In deciding to the choice of hormone therapy, considering should be given the dose, route, and the regime. Addition of progesterone must be incorporated to the estrogen therapy with an intact uterus. And typical starting formulation for women with POI includes transdermal estradiol in a daily dose of 100 microgram, oral estradiol in a dose of 1 to 2 milligram per day, or a conjugated estrogen at the dose of 0.625 to 1.25 mg daily. And patient must be advised to maintain symptom chart. Hormone dose should be adjusted to achieve the level of symptoms control and translate an optimized quality of life. So HRT in a POI in a special issues in a Turner syndrome, that should be given girls, women POI due to syndrome should be offered HRT throughout the normal reproductive lifespan. If there is a breast cancer and a BRCA gene mutation, HRT is generally contraindicated in a breast cancer survivor, but it's HRT treatment option for women carrying BRCA mutation, but without personal history of breast cancer after prophylactic bilateral salpingo-oophorectomy. POI and endometriosis, it's required the oophorectomy, combined estrogen progesterone therapy, effective treatment of the vasomotor symptoms, and reduce the risk of disease reactivation. Now, the risk of HRT, all of us know, this is because of the breast cancer, and another is endometrium in the intact uterus. But options are 17-beta estradiol preferred to the ethinyl estradiol or a conjugated equine estrogen and the replacement. Preference of route, method, administration, it depends upon the patient and what is best, it should be given. Monitoring is another important part. Once established the therapy, how long it should be given, how the clinical review annually should be done, how to pay attention to the compliance, and no routine monitoring tests are required, but maybe prompted a specific symptom concern. So the treatment with androgens is another very important point. Its effect should be evaluated every 3 to 4 months, but if possibly limited to 24 months. So these are the basically a chart of a, you can say, algorithm for how to go for the for POI and how to diagnose it and how to treat it. It's very important. Just sorry for this. So while doing the clinical examination history and examination in initial investigation of FSH, SCG, TSH, sonography levels we'll see and how to confirm it. Then investigation continue if there is a iatrogenic or a spontaneous POI. It can be the history of chemotherapy or radiotherapy. Then the karyotyping comes. There is a fMRI permutation. Then the things are like that. And it's testing Turning syndrome. That's also there. Sometimes the basic autoimmune screening we should do and find it out and consider the investigation. And positive anti-adrenal antibodies refer to the specialist to exclude Addison disease, positive thyroid autoantibodies, annual TSH, we should exclude the celiac diseases. So these are the important MHT, the hormone which we should give. In the vasomotor symptom, yes. Genitourinary symptom, yes. Bone health, yes. Cardiovascular, yes. Sexual function, yes. Life expectancy, it's a question mark. Quality of life definitely improves, and neurological function is again the question. So the take-home message for the historically considered the poorly understood and a catastrophic condition, etiology has been largely considered idiopathic. Recent advances into the field of genetics to unravel a complex network of molecular pathways and many potentially promising diagnostic and treatment modalities are already being explored. Another important things are opportunities for an earlier diagnosis in those at the risk of POI. Timely intervention may offer salvage to residual reproductive potential in early stages, and effective freezing of the oocytes and ovarian tissues are tried and tested interventions. So a summary is a vast majority of cases with idiopathic, short-term and lifelong implication of the health, timely initiation of the hormone therapy and a multidisciplinary approach, Thank you so much for patient listening and given me the chance to speak today. Thank you so much.
Thank you very much, ma'am. We are very honored to have you, ma'am. And it was very informative, and we are here to learn you, ma'am. Thank you very much, ma'am, for the wonderful presentation. Ma'am, if you allow me, then we'll take the questions.
Okay, no problem.
Yeah, thank you, ma'am. Ma'am, we have a first question.
Yes.
That is there any evidence of ovulation induction POI can be really achieved with gonadotropins or GnRH analogs?
To be honest, with whatever the modalities you use for the if we have diagnosed it's a premature ovarian insufficiency with the FSH level, the estradiols and everything, and then still we are talking about the gonadotropins given or how to increase all those things, it's not possible. So I have already suggested it. Out of 5%, they ovulate or spontaneously, I don't know how. And another important point is they ovulate also and the pregnancy is there. But for the premature ovarian insufficiency, the best treatment is the ovum donation. You may do whatever things, the PRP is there, there is a stem cell therapy is there is a ovarian transplant is there, there's so many things are there. But the time and tested thing is, which we always talk about, that is, this is the most important, is oocyte and ovarian tissue is very, very time and tested. Given gonadotropin and everything won't work if it's a real comes into the definition of POI. Sometimes if the patient is taking some chemotherapeutic agents or the radiation agents, so wait and watch, sometimes it reverses back. But if there is this all the FSH level is low, estradiol is gone, amenorrhea for 4 months, the chances are less, and the best is freezing oocyte. Ovarian tissues are best for the treatment.
Thank you, ma'am. And I think there's one more question from Dr. Sangeet. Premature ovarian failure and management, I think already you have discussed.
Yes.
Ma'am, there is one more question from Dr. Jayashree. Stem cell for ovarian failure. What is the present situation?
The researches are there, there people are talking, people are doing stem cell and many more things are going on. It's a going on research process, but at least we need it. There are 2 types of stem cell therapy basically for the residual file rescues. There's going to be an injected bone marrow derived stem cell that can be a BMDSC, and another is a peripheral blood mononuclear stem cell therapy is there. But yet we have to go to very high level. There is some ethical committee to sit on it. There should be the evidence-based results, and there should be so many things to be looked after before doing it. It can be a thing like given a PRP, or we can give a tissue cryopreservation, so many things. But people are doing good results are there. Some Indian people have done with PRP and everything. So I think there are chances, but from my knowledge, yet we are abhi humko der hai. It's a long way to go.
Thank you, ma'am. And ma'am, we have one more question. Chances of success rate for embryo transfer in POI?
I think it depends upon this is the only best method to use the donor eggs, which can improve the conception rate. So depending upon the other factors or the what they call it, what are the rates, not rates, what are the result rates or anything of that particular institution, there are good chances with the use of donor eggs, and they are improved, right? Because the endometrial cavity is good, except the follicular depletion and destruction is there. So the donor eggs work very well to these patients.
Thank you, ma'am.
Thank you so much.
Yeah, ma'am, there are no more questions from the delegates. If any questions, definitely we'll forward to you.
Thank you so much. I think
Thank you very much, ma'am.
we are done for today. Thank you so much for giving me the chance. And I'll be a part of your programs in future also. Thank you.
Thank you very much, ma'am. Many thanks from the Shield
Thank
team
you,
and
ma'am. Thanks so
for
much.
your kind support for the educational activity. Thank you, and I also thank all the delegates for active participation. Thank you, and many thanks from the Shield team. Have a good day.